My name is Alan Wong. I'm the president of the American Academy of Developmental Medicine and Dentistry, and I'm so pleased that you're joining us tonight. We have a wonderful panel of speakers on the topic of sleep disturbance. I apologize for the background stutter there, but nothing to be worried about. That will work itself out. Sleep is such an important element in everyone's lives, and we particularly want to highlight this in this population with disability. We know that people have disabilities throughout the world. It's one in four have a disability of some sort. We know that in certain populations, they're more afflicted, and sometimes they're not even looked at because there's so many things going on. Tonight, we get to highlight some of that and give you some information. And I'm going to introduce you to Cindy Lee, our moderator tonight. So Cindy, tell us about our panelists.
Thank you, Dr. Wong. Hey, everyone. Welcome to our March 2022 virtual grand rounds. It's so good to see everyone here. My name is Cindy Lee. I'm a fourth-year dental student at University of Pennsylvania School of Dental Medicine in Philadelphia. And this year's American Academy of Developmental Medicine and Dentistry virtual grand round facilitator. For those that are new today, virtual grand rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the grand round sessions is to expand and strengthen the IDD healthcare workforce across the spectrum of all the experience levels. So thank you guys all for joining today. If you guys have any questions throughout our panel tonight, you can write your questions in our Q&A box on the sidebar. Any unanswered questions will be discussed at the end of our presentations. So please make sure to send any of your questions in our Q&A box and not the chat box. Now I'm going to go ahead and introduce our amazing panelists for tonight. And we'll be talking about sleep disturbances in persons with IDD. And first we have Ms. Barbie Vartanian. She is our parent advocate and mother of Sam. She has been also a board member of Project Accessible Oral Health. So thank you for being here. And we also have Dr. Shelton, who is an associate professor of neurology, and she focuses on pediatric sleep disorders at Vanderbilt University Medical Center. Thank you for being here, Dr. Shelton. And lastly, we have Dr. Vaughan, who is a clinical assistant professor of orthodontics at the University of the Pacific School of Dentistry. And thank you so much for being here.
Thank you.
And that being said, please welcome all of our panelists for tonight. And I'm going to go ahead and turn it back to Dr. Wong.
Thank you, Cindy, and thank you, panelists, as well. And I see a lot of people coming from all over the country and outside the country as well. So welcome. This topic is very near and dear to everyone's heart. And I just wanted to start out the conversation with Dr. Shelton. Maybe you can give us an overview in terms of sleep disturbance from pediatric and how you got involved in this particular population. So why don't we just start off with that?
So I initially was doing a fellowship and finished a fellowship in epilepsy. And while doing my fellowship, I actually saw patients at a home for patients with IDD. Now this home is closed down, but this used to be where, unfortunately, patients with IDD were sent to. And so I really became interested in their overall health. And one of the complaints that the caretakers always had was they don't sleep well. They're not sleeping well. And so I tried to further my interest in IDD and sleep by getting to know Beth Mallow, who is the head of our division. And at that point, she had a research project looking at Angelman syndrome and sleep. And so I got involved working with her with Angelman syndrome and sleep. And then it really just took off. I really enjoy working with patients with neurodevelopmental disorders. I right now am doing a clinical trial with patients with PWS, which is Prader-Willi syndrome. I'm also the sleep doctor of the multidisciplinary Prader-Willi syndrome clinic. So that's really how I got involved. I think it stems also from childhood. I have my middle brother is on the spectrum. And I started this way before I had my son, but my son, Nathan, is also on the spectrum, so.
Thank you, Dr. Shelton. So in medical training, how much training do you get in sleep and particularly in this population?
None. So
Okay,
if you want it, you really do have to seek it out. So I would say this, in medical school, we really aren't, other than what you see and read in your books, this is not, training in sleep is very rare. The medical students at Vanderbilt get to do about a day in our sleep clinic, and that's their exposure to sleep medicine. During that day, they may, in particular, if they're with me, they're going to see a lot of patients who have neurodevelopmental disorders. But that is not the case for the majority of medical schools. Sleep medicine and any rotation with neurodevelopmental disorders is not necessarily a required thing. For instance, even the requirement of neurology rotation, so they are required to do 6 weeks of neurology, but if they don't happen to be put in the pediatric neurology rotation, they may never see a child with a neurodevelopmental disorder. They may see lots of stroke and lots of, other neurological conditions over on the adult side. Occasionally, if they were rounding in our epilepsy EMU, epilepsy monitoring unit, we're going to have adults and adolescents there with neurodevelopmental disorders, but they don't necessarily get trained in that. And so it is a gigantic deficit in medical training.
Okay, we're going to come back to the medical part, but let's turn to dental a little bit. And Dr. Vaughan, tell us a little bit about in dentistry, what people are taught in your field for people with sleep.
Hello, Dr. Wong. So I just wanted to give a little brief introduction to myself. People will probably realize that I've got a funny accent, and they may pick up the fact that I and my wife have come to the US just recently in 2021. Prior to that, I worked in private practice in central London, and I came into dental sleep medicine from very much a surgical perspective. I got involved, I put together multidisciplinary teams, and one was treating orthodontic patients, so that's jaw surgery along with orthodontics, for people that had a positive polysomnography reading and they had severe sleep apnea. So I was involved in that, which sort of gained my interest in the subject matter, really, more than anything else. And wanted to then see how orthodontics itself could improve and enhance the quality of life with sleep apnea. Are there other alternatives other than surgical? And this blended very nicely with our move to the US, starting my career in the University of Pacific, whereby they were beginning to put together a dental sleep medicine or sleep clinic, and tying that in with the University of Stanford, which is just down the road in San Francisco here. So I've become quite involved in looking at use of oral appliances and orthodontic treatment and what that can provide for our patients. And as I'm relatively new and I want to learn more, I'm just starting with the American Academy of Dental Sleep Medicine to do my Mastery 1 and 2 courses to further my education in it. So I feel a little bit of a baby to this all in certain respects, but certainly orthodontics I feel does have quite a lot to offer. And I think quite a lot of it is from the diagnostic point of view. Because of the children that we see, we're in a very, very blessed position that we see them as young as 6, 7, where you can pick up people who have got sort of enlarged tonsils, maybe they've got tongue tie, they've got various things that we know that may be contributory in whole or in part to problems with sleep, but we're also in a position where we can ask many interesting and varied questions to our patient base as well to pick up these things. So I think we're in a very, very nice position to be able to pick up patients that may have sleep disordered breathing, whether it's mild, moderate, or severe. And it's an area that I really would like to persevere and work quite hard in. I also, at the very beginning of my dental career, also worked in London in the community dental service for about 5 years. So we treated quite a large proportion of patients with medical, physical disabilities. And certainly that started my passion, really, looking at patients that unfortunately don't seem to get the same level of care sometimes as I feel that they really should. And so I think if you can bring dentistry and medicine together to improve the quality of patients' lives at a very young age, that stands them in good stead for the rest of their life. And so that's sort of my passion. That's my introduction to this subject.
Thank you. And just in medical as well, we're not very well trained in this area until now. I think it's a developing area, and I think we can both agree that early detection is very important. But in this population, a lot of things are diagnostically overshadowed. We don't look at things that we don't think about. So I'm going to turn to Barbie from a parent perspective in terms of when did you first notice your son having some sleep disorder?
So I have to start by saying how ironic it is. So I can hear Sam snoring in the background, and I was telling our panelists before we started that last night we had a really rough night. Sam was up at 2, and the reason why he was up is we kind of shifted his schedule today, and that's just kind of some of the things that happen with Sam. Is if he feels like there's a shift in what he knows to be, Bible, and it doesn't happen, we kind of tend to have these issues. So I've been up since 2 a.m., so I'm a little bit tired myself. So when Sam was a baby, I had a 12-month-old at home, so no one was sleeping. So it was we really didn't detect anything. Like my son and my daughter are very close in age together, but so as he got older, though, we started to notice some sleep struggles, and mostly it was around shifts again in his change of routine, and it kind of manifested itself in kind of anxiety and things like that. And so he would walk the halls and come into my room and kind of just really look for me to engage with him. But it wasn't ever, too difficult to get him back or get him settled. But as he got older and he went through puberty, Sam's 13 now, and I have to say he's pretty profoundly autistic. He's nonverbal. And as we went through puberty and the pandemic, which was amazing to go through both at the same time, Sam did not sleep. I mean, literally for the past 2 years. We would wake up in the middle of the night to Sam smashing his head against the wall. And, and he very effectively put many, many holes in his wall in his room because he was in such distress. So again, for 2 years, we didn't sleep. We ended up, we put Sam on medication during the pandemic for which he was never on before. And we went to his doctor and we said, hey, should we do some sort of sleep medication? And she recommended just trying to give him a dose of Benadryl, in conjunction with his other medications. And thankfully it worked. And kind of, what was happening in the middle of the night subsided, and he's doing much, much better. But again, like I said, last night we were up all night. So it's really just, you never know, like, you could have a week or two where everything's great and you're getting a lot of sleep. And then all of a sudden something happens, something triggers, and you really honestly don't know. Is he having a medical issue? Is he having, anxiety? You just really don't know. So I have to say, if you're a parent of a child with a disability, we're tired a lot. So, and for very justifiable reasons. So yeah, it's a roller coaster.
And thank you for sharing with us, Barbie. I know this is kind of a tender subject, but I mean, it's not just a patient that's involved, it's the family around that's involved as well. So how does that interplay I mean, you must be exhausted from many nights.
Yeah, it's tough. And it's hard, and it's tough. So like I mentioned, he has a sister who's 12 months older than he is. And, and when we were going through the pandemic, I mean, Mary Lee didn't sleep either. So it was a lot of us up at night trying to get Sam settled and trying to make sure that he wasn't hurting himself and things like that. So it has a tremendous effect on the family. And so trying to work a full-time job and care for your family and do all these things and continue to fight and advocate for your child and being already exhausted in that regard and then not having his sleep to back it up, it's tough. It really is a difficult situation. And we all know that how important sleep is. Like if we don't have a good night's rest, it's tough to do anything well. So that's a challenge.
Thank you, Barbie. I'm going to turn over to Dr. Shelton. Maybe you can overview some of the negative parts of not getting good sleep. So physiologically, I think Barbie mentioned a little bit of it, but.
Yeah. So first I want to tell you, Barbie, that I feel you. So I think one of the best things that happened to me as a physician was having a child with a neurodevelopmental disorder. Because although I had a brother, I was a child then, and so I didn't understand it from a parent perspective at all. And now I always say that God is very funny because I'm a sleep doctor, and he gave me a child who doesn't sleep. And so I understand when a parent comes in and they're crying because they haven't slept. And so one of the things that I focus a lot on with my biggest concern. So the parents always want to know, how is this affecting my child? How is them not sleeping because of whatever underlying sleep disorder they have affecting my child? And that what I focus on first is cognitively. So if you have someone who's not sleeping, even if they're typically developing, they are not going to be able to attend and focus in class. And so, chronic sleep deprivation can cause ADHD-like behavior. When I talk to my parents who have patients with neurodevelopmental disorders, I talk about progress in their therapies. Why are we not making progress in speech or progress in physical therapy? And a lot of, so sleep, that is learning. And so sleep does cause learning problems, lack of sleep can cause learning problems, attention problems. And then I go back to mood. So as an adult how you feel when you are tired and haven't slept. You get frustrated easily. Your coffee drops and you think it's the end of the world. So imagine how a child feels who, first of all, their frontal lobes aren't fully myelinated and they're nonverbal. So they can't even tell you how bad they feel. And so you start to have more challenging behaviors. Maybe they're going to have more repetitive behaviors like stemming. They're going to script more, those types of things. And then in school, get frustrated with their peers more. Maybe if they were sleeping well, if Johnny came and took that car away, they would not lash out. But because they're not sleeping, they're having more challenging behaviors. So that's my first focus when I'm talking about pediatric patients. Yes, there are cardiovascular consequences for that we know that chronic sleep deprivation, especially if it's due to obstructive sleep apnea, can cause. But when I'm seeing someone acutely in the clinic, someone on the spectrum, I'm not too concerned about those cardiovascular consequences because that is chronic sleep deprivation over many years. We're dealing with the acute problem at the time, and the acute problem is mood, behavior, and learning.
Well, certainly mood and everything. And I think that a lot of times medicine goes towards stabilizing mood by more medication and not dealing with the etiology of the situation at times. I don't know. What are your thoughts on that, Dr. Shelton?
Yes, I feel that is true. So I end up seeing patients who are on a lot of medications. And so sometimes I think that we, in order to we look at the mood disorder, or why are they having this kind of defiance, or why are they having this aggression, and we don't get to sleep until the very end. My best example is I was on a community health panel for pediatrics with our local health department. And they had things that they wanted to focus on. They wanted to focus on ADHD, truancy. They wanted to focus on, a behavior. And I raised my hand and said, well, I see all of these things that you want to focus on, but why aren't we trying to also address children's sleep? And they said, why would we address sleep? Like literally, that's what they said, why would we address sleep? And I said, because sleep or lack of sleep affects all of this. And so it's not necessarily the provider's fault. If you see someone that mainly treats mood and behavior, they're going to focus in on that mood and behavior. What I find is they focus in on the mood and behavior, and the medicine isn't quite working well, and then they dig into, well, what else is going on? So I see, I end up seeing children years later when everything else hasn't worked, and then the parent comes and said, I was telling my pediatrician that he wasn't sleeping well, or telling my psychiatrist that he wasn't sleeping well, but they never said, they didn't really address that until now. And I think the more we understand about sleep and the more we get the word out, that's when the pediatrician is going to start thinking about sleep. For instance, one of a person in the chat box talked about, wanted to know more about this ADHD-like behavior, or if you have ADHD, it worsening. And I find now I have a lot of patients coming to me that say, I'm concerned, my pediatrician is concerned that my child has ADHD, but my pediatrician told me we need to look into sleep before we prescribe medication. And I would say that's happening more and more in the last 3 years. 10 years ago, that didn't happen. And so I think the more we talk about sleep and the effects of lack of sleep to our community providers, to our parents, so the parents can address this, then I feel that will at least pause on the medication first, and come back to that. There are times I completely understand where the behavior or whatever is going on is so intense that we have to use medication and address it so that the family can be safe, so that the patient can be safe. Sometimes that has to happen.
Okay, very good. So there are sometimes things that are very obvious: the loud snoring, the head banging, the sleep disturbance. But I'm guessing there's a certain population that have sort of subclinical things that not quite as noticed as well. And I'm going to talk to Dr. Vaughan in terms of what are some of the signs that we look for that are early tells of someone that might be in this category, and maybe they don't exhibit all the classic manifestations maybe that you see.
Yeah. Well, thank you very much, obviously, for sharing the story and the journey from the previous speakers. I think as orthodontists, it's a bit like pediatricians. We have a very unique profile of patients that we see and treat, and they trust us. And I think it's incumbent upon us to clinically examine these patients from our own professional viewpoint of orthodontics in this case. But certainly when we are also given the opportunity to look at aspects of them, medically speaking, that could give us an indication that there may be something more afoot, or that there is something underlying, but maybe, as you say, at a sort of a more suboptimal level, but nevertheless may be impeding their health at that time, but maybe also that would impede their health going forwards into adulthood. So, when we do our clinical examination, it will be a mixture of questions and examination. We are trying now to ask very, very more specific questions relating to their sleep and their behavior, and do they snore? Do they bedwet? Do they have lack of concentration in school? These sort of questions. But I think on clinical examination, which is the question you're asking, it's very much more examining their mouth. Are we, looking to see if they're a mouth breather, for example, whether they have a tongue tie, so their tongue is more lower in the mouth, so that they don't get the development of the palate as they would normally, as deferred as would be recommended as normal facial developmental growth. Are they a mouth breather? So can they actually get their lips together at rest, or do they actually have quite an open mouth? That can sometimes be reflective that their lower jaw is a little bit small from a front-back dimension. And clinically, if that's the case, you'll find sometimes there's a vertical discrepancy and a width discrepancy with their jaws, which again can lead on to airway resistance problems, this sort of thing. We can also look to see if there is any wear patterning of the biting surfaces of their teeth. That would be quite reflective that they may be clenching or may be grinding, and that can be associated with problems with sleep. And not being able to breathe correctly when they're sleeping, and also they may also have something called GERD, which is they have reflux, which basically is also associated with sleep apnea and erosive patterns on their teeth. So we can look at their teeth, we can look at the soft tissues in the mouth, look at their tonsils, whether they've got tongue tie, whether they've got inability to bring lips together, as well as looking at their face to see their jaw relationship in terms of their front back of their jaws, their width and their vertical dimensions. These all have an impact on their airway. One can also have a look at their nasal passages as well, although we're not examining them in detail, but certainly you can see if there's nasal septal defects, whether there's an asymmetry, whether there's a narrowness. And that in combination with questioning can give quite a lot of very useful information at a very subclinical or clinical level for diagnosis purposes.
Okay, very good. So we're here to talk about the anatomical limitations, and the gold standard really is the sleep study, the polysomnography, but in this population that really cannot have all these monitors on their things, how do you detect this, or how do you diagnose this, Dr. Shelton?
So I wanted to point out some more subtle signs. So sweating in sleep. So someone is a very sweaty sleeper. So they're retaining CO2 because they're not effectively blowing it off. So now they're sweating. And then very restless sleep. They're tossing and turning all over the bed, sleeping in strange positions. I get probably only about 50% of my patients that tell me they snore, as far as my pediatric patients. And you have to remember that a lot of kids with neurodevelopmental disorders have low tone. So they can't really develop a nice, robust snore.
Right.
And then morning symptoms, morning headache. So they're retaining CO2. So every morning they wake up with a headache. If you're nonverbal, one of the ways that this can present is incredible, lots of irritability upon awakening, but also vomiting, nausea and vomiting. So they have this really bad headache, they're retaining CO2, they feel nauseous, so they're vomiting in the morning. And those types of things, which aren't the kind of things that you think about that kind of say, yes, this is obstructive sleep apnea, such as snoring and gasping, are there. So those are more subtle signs that I often have my parents tell me. Interestingly, as far as the sleep study, were you going to say something, Dr. Vaughan?
No, I'm just fascinated. Keep going.
So interestingly, as far as the sleep study is concerned, I have a lot of parents that are concerned about the sleep study. I've had, so home sleep studies are not FDA approved for pediatrics, and there's a big reason for that. But I've had some of my older teenage patients that, let's say, have Angelman syndrome. They have a lot of sensory issues that I've ordered home sleep studies on, just so that we don't change the environment. But the majority of my patients with neurodevelopmental disorders come into the sleep lab and they're able to complete a sleep study. It just takes a little bit more preparation. So one of the things I tell the families is, for 2 or 3 weeks before the study, start prepping them by putting little small Band-Aids on their face, round Band-Aids, so they're used to having this something on their face. If your child is more verbal, develop a social story so that they know what's going to happen. I love the first and then. So first we're going to do this. First we're going to do with pictures. So we in our clinic, we actually have first and then boards, and we have pictures that they can apply with the Velcro of someone with wires on their head, which is supposed to be the sleep study. And so first sleep study, then reward. So first and then board is really good for a child that is not verbal, and you have to continuously remind them first and then. Sometimes what I do is have the child fall asleep first, and then we apply the electrodes. Sometimes we go ahead and apply the respiratory belts and then wait for them to fall asleep and then apply the electrodes. If I am not averse to giving them, let's say, a melatonin that night if they don't take melatonin. If they do take melatonin, I tell them to continue taking melatonin. Melatonin in no way changes the sleep architecture or is going to give you like more respiratory events per se. Our sleep labs are hotel based, so ours are not in the hospital. So that also helps, because when you tell the child, you get to stay in a hotel with mommy, away from your stinky brother or sister, you get all the attention. That helps also, not being in the hospital. And we purposely took our sleep lab out of the hospital because of that.
Okay,
yeah.
Very, very good, helpful hints. So first, we're going to go to Cindy, and then we'll come to the panelists for questions. So Cindy, do you want to field some questions that are popping up for us, please?
Sure, we have a lot of questions that are coming, so hopefully we can get to all of them. But before we do, I know we have a question for Ms. Vartanian. I know you're serving as a director of oral health advocacy and policy initiative at NYU. Just wanted to hear more about what you do there and how it's been helping with your advocacy and policy initiatives.
Yeah, absolutely. So this is actually a very, very new role for me. And it was one that is just very newly created at the university. So I'm very, very excited about it, and actually sits in 2 different departments. One, the Center for Oral Health for Persons with Disabilities, and the incredible facility that NYU put in probably just before the pandemic, about 2.5 years ago. And then also in this new Policy and Leadership program that is being spearheaded by Rick Valkovic, who is the former president, I believe, of IDEA. So, we're really trying to just work with our partners like Alan and the AADMD and all the national advocacy organizations to move the needle in all the different, areas around oral health. So whether it's looking at reimbursement change, whether it's looking at curriculum changes, it's just all of the things that we need to look at in terms of making sure that the health equity for people with disabilities is what it needs to be. So I'm really, really excited about, the evolution of this new role and what, and making sure that NYU has a seat at the table in all of these discussions as the largest dental school in the country. So thank you for the question.
Yeah. And following up with that, as a parent, was there anything that you did to kind of mediate early intervention for Sam and his behaviors early on, or was there anything that you did to help?
So in terms of sleep, not necessarily, because I didn't really know. I always felt, whatever issues we were having with sleep, in the early days, I always just kind of attributed it to the autism. And so that's, there we go back to like that diagnostic overshadowing. Like it probably wasn't just the autism. There was probably many factors that Sam was probably going through. But, in terms of just, the day-to-day, things that Sam goes through and the behavioral challenges that we've had, like as a parent, and I'm sure many of you that are on the call, like, and Althea can attest to, we just have to be their best advocates. We have to be, my word has always been relentless, because if we're not going to do it, no one else will. Like, we're used to being told by the insurance companies, that they're going to deny our claims, or there's these incredible wait lists, or, again, going back to, you go to the doctor and they tell you, oh, it's just because he's autistic. And you're like, well, no, he's got, a terrible, GERD issues, or he's got this, Sam's been going through these incredible ingrown toenail problems that, it took us a little while to, figure out that he was having incredible pain there. Like, when you have a child who's nonverbal, you're constantly like, and because I'm in the oral health space, I'll get on the phone to, Dr. Perlman or Alan, I'll be like, what's going on in his mouth? Is it his mouth? Like so there's so many things, it's a guessing game. So, but I think the biggest thing that you can do as a parent is you have to be relentless for your child. You have to, I moved all the way from California to New Jersey because the resources were better, so you just have to, and I'm not telling people to do that. That's crazy. But, you just have to continue to just turn every stone, and you have to just continue to fight for your child and do whatever you can to make sure that they live the best possible life.
Barbie, I'm curious about the family dynamics that exist. Clearly, the individual that is experiencing these problems, we can see that in a variety of ways. We know they're suffering. We know the parents are dealing with it because you're verbal, you can express it. I'm interested in your daughter, in the sense that your son is getting obviously an extra attention because he needs that attention. How does your daughter feel or deal with the fact, though she understands your son needs this attention, she to some degree may feel like she's being left out because she doesn't have this extra, so to speak?
Oh my gosh, I love
into the family situation.
Yeah, I love that you asked that question, Ben, because that is literally something that like I lose sleep over, besides Sam being up, is my daughter, Mary Lee, and the dynamic between the two of them. So the hard part is because they're so close in age and they're, brother, sister. And so you're trying to peel back that relationship and that dynamic. Is it just that, or is it, is there resentment? Is there, this, why does the squeaky wheel gets the, the attention and things like that. So I, as a parent, have always tried to, I'm so intentional about that relationship. I don't, because after I'm gone, Mary Lee is going to be Sam's person. So I don't ever want her to resent him. So I try to be, again, very intentional about the relationship. I try to be, open lines of communication as to how she's, navigating life with him and making sure. And again, like a lot of it is just this brother-sister dynamic. And I know she loves him more than anything, but, there's times where I'm like, oh my gosh, this is Mary Lee, you've got to, suck it up, so it's tough I have so much, just gratitude and empathy for the siblings, and we don't talk about them enough, and understanding what that dynamic looks like and how important their role is. And again, after we are gone as their parents, like that's their person. And so what that looks like, it's a special relationship. And you always hear, it's either really great or it's not. Like I've heard so many different scenarios where they're right there side by side with them and they take care of them and they live with them. And then you hear other stories where they put them in a home and they never talk to them again. So it's something as a parent you grapple with. You're like, I hope that, I hope that I'm setting her up for success. So I think about that every day.
And how does that stress wear on you as an extra level? I mean, you're not just talking about not getting sleep. You now have the stress of trying to deal with that ongoing situation that sometimes it's just normal siblings, normal fussing and fighting, and then sometimes it's a little bit more than that, and you're dealing with that, and that's stressful for you. And how do you manage the stress that's this added level or layer?
Oh goodness, very carefully. I honestly, like, as silly as this sound, like laughter, like just trying to make sure that, you know, you make light of things, you know, like just kind of taking the edge off certain situations and trying to, you know, make sure that everyone's in a good place. You know, because if it gets too heavy, for my daughter, I can tell when she pulls back. So I try to just, again, try to make light of some of the things and make sure that she's, you know, always in a good place, as difficult as that can be. And again, you know, Ben, I don't navigate it probably well enough. It is very stressful for me. Like what I always, and I have to stop doing it, but I always think about what life will be like after I'm not here and what the dynamic between the two of them will be. So it's not, again, I probably could probably do a better job of that, but you're as a parent of a child with a disability, you're always in this moment and you never know what's going to come at you next. Like it's just, I always feel like I'm just trying to keep my head above water a lot of times. And so I just try to do the best that I can and let her know how much I I know Sam knows, but just making sure she knows how much I love her and how important she is to me. And I just try to constantly remind her of that. So.
Thank you for that. There's another question. We have an audience who sharing about how they have autism and sleep apnea, and they've tried everything, including CPAP, continuous positive airway pressure, and BiPAP, but they can't tolerate either one of them because of their GI distress. And tonsillectomy, adenectomy did not affect it at all. Is there anything that you guys recommend, or what more can they do?
I saw that Dr. Wong put what I would have recommended. So first of all, we need to know if it's mainly an obstructive component. So there are a couple things. One, I would go to a sleep dentist or some type of orthodontist like Dr. Vaughan to see if there's structurally anything that can be done. I've had a lot of success. Unfortunately, I've not been able to get coverage in my Medicaid patients, but if a patient has private insurance, I've had a lot of success in sending my teens and young adults to to look at what's going on structurally, because oftentimes, like Dr. Vaughan said, they have retrognathia, micrognathia, they have a very small mouth. So that's number one. Number two, if there's no structural component, then you could consider a hypoglossal nerve stimulator, like Dr. Wong said, like the Inspire. And there would be an ENT that did that. So if you look on, if you Google hypoglossal nerve stimulator, or even easier, Inspire, they will have a list of places that are trained to place this device. It is a device that almost looks like a pacemaker, except it goes on the right side. It wraps around the hypoglossal nerve. There is a magnet to turn it on and off. So you turn it on in the morning, on at night before you go to sleep. And every time you have an apnea, it detects it and it slightly pulls the tongue forward, because the hypoglossal nerve controls your tongue. So that is an option too. I don't know if the other people have other options for them.
Thank you, Dr. Shelton. Yes.
Clearly, it's important to try and realize what the obstruction is, where it is, or what areas it is. And certainly, if it's sort of, you know, the mouth to the oropharynx region, it's very important, I would suggest, for a pediatrician and for an orthodontist to see such a person, just to reinforce, just to rule out, are there any structural aspects, either with the soft tissue, or indeed with the dentition, or indeed with the skeletal parts of the lower third of the face, you know. And if orthodontics has any ability to improve or reduce those, which may or may not have a direct or indirect reduction in the symptoms that are being experienced.
So how successful in general would you say percentage-wise something like CPAP works with this group compared to someone without an intellectual disability?
There's not been a lot of studies that look at CPAP adherence in patients with neurodevelopmental disorders. Dr. Carol Marcus has, I think, one of the most recent ones that came out. And I believe, if I remember the percentage correctly, it was actually surprising. It was about the same percentage as you're typically developing kids, which is about 40%. And in that study, the people, the segment of population that was most adherent to CPAP or PAP or females with Down syndrome, I'm not sure why. But they were the most adherent group. And so it's about 40%, which is about what you have in a typically developing population of children also.
Are there any particular situations where you feel like you really should not start CPAP that you would otherwise think maybe don't necessarily seem to be visible? Situations that you just say this is a case where CPAP shouldn't be used, something going on with them?
I get concerned when, for instance, they have something like a Nissen fundoplication, so some kind of GI issue that having a lot of extra gas may actually be very painful. I have some kids who have air trapping because of oral motor issues, so they trap a lot of air, and I find that CPAP is not really good for them because that also is just going to worsen the problem and maybe cause more pain. And if they're nonverbal, they can tell you they're having pain. So those are a lot of it ends up being more GI issues. If they have a chronic like vomiting situation where they're constantly vomiting, or that I get concerned with CPAP at that point too. Although I have used it in that situation, but I use a nasal mask or a nasal prong. I have patients in certain populations that are very much self-harm and do dangerous things where they can't have any electronics in their room and they have to have a bare room, and that CPAP is not good for that population either.
Compared to others, how much is there extra time or training that seems to be necessary that goes along with this, that you feel like that you're going to have to invest so much more time? Does it seem like there's a fair amount of extra time that just to make that initial adjustment?
I don't do this by myself. So we have a behavioral psychologist, and a lot of other university programs have a behavioral psychologist or behavioral psychologists that are trained in sleep. And so we have Dr. Whitney Loring, and she is wonderful. Her training is working with children with neurodevelopmental disorders. So almost all of my children that have neurodevelopmental disorders that I'm going to start with CPAP, I send to her, and she works on acclimation with them. And I always tell my parents, this is a marathon, it's not a sprint. So there's, I find if they're wearing it a couple hours, 3 months and down the road, I'm so excited. They're wearing it a couple hours. And the parent is like, but they're only wearing it 2 hours. Yes, you have insurance issues, like the insurance company is going to say, I'm going to take it away. But usually once I write the insurance company a letter, they will give us more time. I've had the insurance company give us up to a year to work on this. And I always tell my worst patient was a young girl with CP and epilepsy, and her epilepsy was going out of control because uncontrolled obstructive sleep apnea or chronic sleep deprivation does cause an increase in seizure frequency. And she would literally throw the CPAP at her mother. And we worked on this for 3 years. And I'm so happy her mother didn't give up, because I almost gave up. Something happened on year 3. Finally, some of the things we were doing, she wore it one night and she was verbal. So she was able to tell her mom she felt better. And her mom said, that's because you wore your PAP. And from then on, she wanted to wear it. But for 3 years, we had every visit, she wasn't wearing it. She was throwing it. She broke so many of them. It was a battle, but her mom didn't give up and I didn't give up. I almost did, but I didn't give up. And we got her to wear it. And now, so I've been seeing her. I started seeing her when she was 15. She's 24 right now, and she loves her PAP. We just had a visit, about 2 months ago, and she was telling me how much she loves her. She wears BiPAP, her BiPAP machine. So it just took time. It really took time. Yeah.
And there was a question about wanting to learn more about neurological related teeth grinding. What are some of the options for an adult with severe teeth grinding that they can't use any kind of mouth guard at nighttime? Is there any other options for that?
I don't know, but maybe one of the dentists.
Dr. Vaughan?
Yeah, that's an interesting one. To be honest, it's to try and protect the teeth as much as possible, obviously, from the clenching, grinding, bruxism. And obviously they may have some erosion component part of it as well. But the two aspects I would say is, first of all, one would want to protect the enamel on the teeth as much as possible, to reduce any loss of tooth substance. So it would be using fluoride application and just preventative measures to look after teeth as much as you can. But in terms of interposing something between the teeth, unfortunately, it's really trying different types of anti-bruxism type splints, be them of hard material, soft material, being partial coverage on the teeth, full coverage on the teeth, be it on the upper teeth or the lower teeth. So to try different combinations of different materials and different, be it the upper jaw, the lower jaw. So, maybe to try different combinations of things rather than just maybe one standard anti-clenching, anti-bruxism type splint. I don't know if different splints have been used.
I think that the etiology of the grinding sometimes has to be, is it the medications or is there some neurological problems? There are other treatments such as Botox for those with severe bruxism as well, but trying to find out what is the etiology, what's the cause? Is it emotional? Is it sleep related? And I think there's a lot of things to untangle there. So I don't think there's a single answer, but I agree with Dr. Vaughan that there is a multi-approach, not one thing works for everyone. And I think this is part of what this conversation is all about, to talk about that there's different people with different manifestations of sleep disturbances. And that's why this year, Dr. Shelton and Dr. Mallow are our guest editors and creating what's called our sleep monograph, bring this to attention from different aspects and different disciplines. And we hope to have this monograph at our upcoming meeting in June at our annual meeting to talk more about this. So we're trying to whet your appetite. We're kind of coming close to the time that we have. Some great questions that I see here. I saw one that I didn't think about, but how sleep can affect vision. That's another sort of thing, but sleep is sort of foundational, not only emotional, but foundational for development, as we know. So in the last few minutes, we'll go around the table here and any last comments from our panelists. We'll start out with Barbie. Any closing comments?
No, I mean, I really enjoyed the discussion and I was taking notes of some of the things that Althea was saying in regards to things I could actually look for Sam. But, just in terms of providers and those that care for our population, the sleep issue is twofold. It's the parents being exhausted because of the life that we lead, but then we have our kiddos that we support and they're going through a lot of things as well. So you just always want to remember and have that empathy for our population, and always remember that when you're caring for them, that there's so many other things that could be going on behind the scenes. So thanks for having me.
Thank you. Dr. Vaughan?
Thank you very much for inviting me to the panel. It's been very, very stimulating. I've loved, if I may say so, Barbie's story. I think she's a model parent, may I say, in terms of the unrelentlessness of her pursuit to help her beloved. I think it's absolutely an amazing model parent story. And to move from, I've moved from the UK to the US. You can move from the West Coast to the East Coast. I think is pretty awesome. So I must congratulate you on your pursuit to try and do the very best as one parent. I'm a parent. I know what it's like, we've had a daughter that's been very ill a couple of years ago, and you try to, you don't leave any stone unturned, just to help them in any small or large capacity that you can do. From an orthodontist, I would say that it's really important to make sure that, every child is seen by an orthodontist, not only for a potential malocclusion of the teeth, but orthodontists nowadays are a lot more aware of sleep apnea and sleep-related breathing disorders and the effect that it can have on a child's development, both in growth, developmentally, socially, and their general health and the relationship that has with their cardiovascular system and their neurological development, this sort of thing. So I think for parents to get their child seen by a pediatrician, to be seen by an orthodontist, I think is important, because there can be some things that an orthodontist can pick up that may not completely, get rid of the problem, but can certainly help to reduce down factors that could be contributory, as I've already alluded to. So I think my closing statement would be, well done, Barbie. I think you've done an amazing job. And secondly, orthodontist.
Okay, Dr. Shelton, closing remarks.
So I, in regards to that grinding, I did think of one option, but you'd have to find someone trained to do it. And if it is more of an underlying neurological issue, possibly Botox injections may be helpful in the right location, done by the right person. And so I would say to the parents to hang in there. I know that you wake up at 2 in the morning and don't go back to sleep. I have, Nathan right now is sleeping okay. But, we've had times where he wakes up at 3 in the morning and then I'm up for the day. And then I cry in the morning before I go to work. So, it's okay. But if you see a change, I often tell parents, you may not see something happening at night, but if you see an unusual change in their daytime behavior, they're not making progress in their therapies, or you see a big change in their mood, look to see what's going on in sleep. And you may want to advocate to be seen by a sleep specialist. Sometimes I've had parents that have been asking to see someone in sleep for 2 years before they come and see me. But advocate, like Barbie said, you're your child's biggest advocate. And so, advocate to see a sleep specialist to at least look into, is something going on in sleep that's causing these changes that are happening.
Thank you. And it's been amazing and very quick 1 hour. You've really opened my eyes. I didn't fall asleep at all. This is great. We'll be having a session of this at our ADMD meeting in June in Orlando, Florida coming up. So I hope that all you can join us there. Thank you so much for being with us tonight. Thank you, Cindy, for being our host, Dr. Warner for being our facilitator, and Adamiola for also being there as one of our hosts as well. And Courtney, thank you for being on the back, leading us there. So with that, thank you for joining us tonight. We have a quick video for you, and then we are out. Thank you again, panelists.